Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Intracellular Therapies, Inc.
Hello, I'm Anita Clayton, the Wilford W. Spradlin Professor and Chair of the Department of Psychiatry and Neurobehavioral Sciences and Professor of Clinical Obstetrics and Gynecology at the University of Virginia School of Medicine in Charlottesville, Virginia. Welcome to this program entitled Expert Update on Current and Emerging Oral Pharmacotherapies in Patients with MDD who have inadequate response. In this segment, I will set the stage by discussing unmet needs in MDD treatment, particularly inadequate response. So let's define response to treatment so we all know what we're talking about. Non-response means little to no improvement in symptoms, so less than a 25% improvement on any given rating scale. A partial or inadequate response is a response that ranges between 25% and 49% improvement on a rating scale, but troublesome symptoms are still affecting functioning. Response is a 50% or greater improvement in symptoms, but not achieving remission. We may need treatment for any residual symptoms. And remission is virtually symptom-free with normal functioning. So with each treatment trial, remission occurs in only 20 to 30% of patients. Residual symptoms can be seen even in patients who do reach remission. Things like low mood, anxiety, irritability, and guilt are often present. Functional problems like lack of interest, work impairment, problems with cognition, particularly impaired memory, and somatic symptoms like reduced libido, sleep disturbance, fatigue, and pain. With inadequate symptom improvement, we also see things like higher risk of relapse or recurrence, more chronic depressive episodes, a shorter duration between episodes of depression, a lower quality of life, functional impairments in work and relationships, increased morbidity and mortality, and an ongoing suicide risk. We might need to alter a treatment regimen for MDD for some other reasons, like intolerance to the medication. This really affects adherence, and that affects the ability to reach or maintain clinically therapeutic dosing. Also, it may be because the illness worsens or recurs. We need to identify this problem early. Earlier identification of inadequate response and a need to change treatment provides a greater potential for improved outcomes. Greater chronicity of inadequate response is associated with worse outcomes. A number of organizations have provided recommendations for managing an inadequate response. The American Psychiatric Association in 2019 suggested switching to another monotherapy only once with a different mechanism of action. So if you started with an SSRI, not a second SSRI, or augment with another antidepressant medication. The Canadian group CanMat suggests considering an adjunctive treatment earlier in the treatment algorithm, especially after an inadequate response to first or second trial, if the agent was well tolerated and appropriate doses were reached. Adjunctive strategies, especially with atypical antipsychotics, show greater efficacy and a shorter time to response versus switching to another antidepressant medication. Monotherapy regimens favored in subsequent lines of therapy despite higher rates of discontinuation versus for adjunctive treatments, happens because we're stuck in a safety zone, and that keeps patients stuck with poor outcomes. These next two unmet needs in MDD treatment are critical for the patient. First, we'll talk about quality of life. When we see that improving with treatment, we're talking about re-engagement, vitality, motivation, ability to feel pleasure, and improved cognition. These changes are associated with increased well-being. Symptoms that often don't improve that contribute to a low quality of life include anhedonia, which is a lack of interest or pleasure in previously enjoyable activities. This is a core symptom of major depression. We also see common non-core MDD symptoms, such as lack of motivation or low energy, or sleep disturbance. These also contribute significantly to quality of life. Now, no single phenotype for a disengaged patient is present, but apathy, like I don't care, is common. And what we need to do is rule out whether this is a medication side effect, like emotional blunting, or due to poor or non-restful sleep. The other unmet need that is critical is functional recovery. Persistence of functional impairment is truly a problem for patients. We want to see them return to their previous highest pre-disease level of functioning. What does functional recovery include? Domains such as family or social relationships, work, domestic responsibilities, self-care, independent living, and community participation. A really key aspect of this is a sense of agency. And I think it's really critical for all of us to feel that we have a sense of agency in where we are going in our lives. Finally, there's a bidirectional relationship between life engagement and functional recovery. So we tend to see both of these things. This points to the need for a holistic approach to treatment beyond just symptom control. We need to incorporate patient preferences into our recommendations, such as avoiding weight gain, avoiding sexual dysfunction, avoiding cognitive problems. These are critical to patients, and one of them may be particularly so for any given individual. The patient profiles most likely to benefit from adjunctive therapy include partial or inadequate responders, those with that 25 to less than 50% improvement in symptoms. Also, responders, those who have a greater than 50% improvement, but they're not in remission. And remitters with residual symptoms, especially with persistent suicide risk, anxiety, irritability, functional impairment, or somatic symptoms and poor quality of life, such as sleep disturbance, pain, and fatigue or low energy. Thank you for participating in this activity. Please continue on to the next segment, where Dr. Citrome will discuss atypical antipsychotics as adjunctive treatment options for MDD.
Hello, I'm Dr. Leslie Citrome, Clinical Professor of Psychiatry and Behavioral Sciences at New York Medical College in Valhalla, New York, and Adjunct Professor of Psychiatry and Behavioral Sciences at Northwestern Feinberg School of Medicine, Chicago, Illinois. In this segment, I will discuss atypical antipsychotics that are currently available as adjunctive treatment options for major depressive disorder, or MDD. Adding an atypical antipsychotic to an antidepressant yields significantly higher response rates compared to using an antidepressant alone, and thus is a strategy we commonly employ rather than switching from one antidepressant to another in the hope of getting an improved degree of response. Approved by the FDA for adjunctive treatment are aripiprazole, olanzapine fluoxetine combination, quetiapine extended release, brexpiprazole, and cariprazine. So we actually have 5 choices regarding the adjunctive use of atypical antipsychotics for the strategy of treating major depressive disorder. Now, one note here, though, is olanzapine-fluoxetine combination is specifically indicated for treatment-resistant depression. The other 4 are approved as adjunctive use in MDD that did not respond adequately to a monotherapy. Let me take you through the available FDA-approved antipsychotics that can be used to treat MDD one by one. I'll go over their mechanism of action, dosing, route of metabolism, and common side effects. Let's start with aripiprazole. The mechanism of action is partial agonism at dopamine D2 receptors, as well as at serotonin 5-HT1A receptors, and antagonism at serotonin 5-HT2A receptors. And this is a bit different than the other choices, as we'll see. The initial dosing is 2 to 5 milligrams a day, and many patients can actually benefit from that. The recommended target range is 5 all the way to 10 milligrams a day, with a maximum of 15 milligrams a day. In the clinical trials that led to its approval, patients were routinely titrated up to the higher amounts. Aripiprazole is metabolized by CYP2D6 and CYP3A4, and this needs to be considered when dosing. Some common side effects, as defined by an incidence of at least 5% and at least twice that seen for placebo, were akathisia, restlessness, insomnia, constipation, fatigue, and blurred vision. Akathisia and restlessness are often confused, and they are dose-related. Quetiapine extended release is the next antipsychotic that we'll discuss. It too, by the way, is available along with aripiprazole as a generic formulation. However, it is quite different from aripiprazole. It works as an antagonist at dopamine D2 receptors, not a partial agonist, and at serotonin 5-HT2A receptors as an antagonist. But of note is an active metabolite, norquetiapine, which is a norepinephrine reuptake inhibitor and is thought to be related to an antidepressant effect that is seen with quetiapine. The dosing of quetiapine extended release is initially 50 milligrams a day, with a recommended target of 150 to 300 milligrams a day, and that is its maximum, 300 milligrams a day. Quetiapine is metabolized primarily by CYP3A4. Common side effects, again as defined by an incidence of at least 5% and twice that observed for placebo, were somnolence, dry mouth, constipation, dizziness, increased appetite, dyspepsia, weight gain, fatigue, dysarthria, and nasal congestion. Of note is somnolence, and this may be an obstacle to its use for some patients. Let's talk about olanzapine-fluoxetine combination next. It's indicated for treatment-resistant depression specifically. It works by combined effects on serotonin, norepinephrine, and dopamine systems. Olanzapine is an antagonist at dopamine D2 receptors and at serotonin 5-HT2A receptors, and fluoxetine is a well-known, well-characterized serotonin-specific reuptake inhibitor. The dosing is a combination of olanzapine and fluoxetine. I'm going to mention 2 numbers. The first number represents the olanzapine dose. The second number represents the fluoxetine dose. And the initial dosage is recommended to be 6/25, with the maximum being 12/50. We start at the lower dose and increase the dose carefully in patients predisposed to hypotensive reactions, hepatic impairment, or slowed metabolism. It is metabolized by CYP1A2, specifically olanzapine, and fluoxetine is a strong CYP2D6 inhibitor. The common side effects were sedation, weight increase, appetite increase, dry mouth, fatigue, edema, tremor, disturbance in attention, and blurred vision. Some of this is related to the anticholinergic effects of olanzapine, so something to keep in mind. The next 2 options I'll discuss are available only as branded products, and they are brexpiprazole and cariprazine, very different from the prior 3 adjunctive antipsychotics that I described before, and perhaps have a more kinder, gentler side effect profile while retaining the efficacy that we would expect. Let's start with brexpiprazole first. Its mechanism of action is similar to what was seen with aripiprazole, but differences are the affinities with other receptors, namely norepinephrine receptors, as well as 5 different receptors to which brexpiprazole binds to with relatively high affinity. In the product label, the mechanism of action is described as partial agonism at dopamine D2 and serotonin 5-HT1A receptors and antagonism at 5-HT2A receptors, similar to aripiprazole, but the actual pharmacodynamic profile is quite different. The dosing is initially 0.5 to 1 milligram a day with a recommended target of 2 milligrams a day and a maximum of 3 milligrams a day. Titration is gradual, and we need to consider in terms of the drug-drug interaction, CYP2D6 and CYP3A4. Common side effects were weight gain, somnolence, and akathisia. However, the rates for akathisia are notably different than for aripiprazole. Last, let's discuss cariprazine. Cariprazine, like brexpiprazole, is only available as a branded product. Its mechanism of action sounds similar: partial agonism at dopamine D2 and serotonin 5-HT1A receptors, and antagonism at serotonin 5-HT2A receptors, but there are other characteristics of cariprazine which are different, namely partial agonism at dopamine D3 receptors, with an 8-fold higher affinity to dopamine D3 than to dopamine D2. The dosing is of interest here. Initially, the recommendation is 1.5 milligrams a day with a recommended target of either 1.5 or 3 milligrams a day. But keep in mind, the main active metabolite of cariprazine, didesmethylcariprazine, has a very long half-life, and so you won't want to titrate cariprazine too rapidly. The product label says that you can only go to 3 milligrams a day after 2 weeks. And then I would recommend a longer period of time. 1.5 seems to be the optimal dose when reviewing all the available evidence. Common side effects are akathisia, restlessness, fatigue, constipation, nausea, insomnia, increased appetite, dizziness, and extrapyramidal symptoms. So keep in mind, akathisia and restlessness are dose-related. And in general, cariprazine is not particularly sedating. Well, let's put all this into perspective, and let's talk about effect sizes. It's different from a p-value, which only tells us if a result is statistically significant or not. An effect size tells us if the clinically observed effect is clinically relevant in the treatment of our patients. Number needed to treat and number needed to harm are my favorite effect sizes. They measure effect size in patient units. Number needed to treat tells us how many patients you would need to treat with one intervention versus another, such as placebo, before you would expect to encounter one additional responder, for example. Number needed to harm answers how many patients would you need to treat with one intervention compared to another before encountering that adverse event you want to avoid. In terms of NNT and NNH, if each of these treatments are tested against placebo, we can look indirectly as to which ones seem to be best. We can take a look at the data regarding response versus placebo. Let's define response as a 50% reduction in the Montgomery-Åsberg Depression Rating Scale. And in this difficult-to-treat population, we reach for adjunctive atypical antipsychotics in order to increase response rates where otherwise they were lackluster with the antidepressant alone. And we can see response rates that range between 40 to about 60% or so. What we do is look at the difference between the response rates for the drug compared to placebo. We subtract these numbers and we come up with the number needed to treat. They range from 7 to 14. I'll take a look at the discontinuation rates because of an adverse event, which tells me about the overall acceptability of the treatment, and they're all pretty good. They're pretty low in terms of their discontinuation rates, with number needed to harm values that are relatively high, which is good. There are some exceptions, though. For example, when we look at the older agents, the number needed to harm is a lower number, which is not good. It means we'll probably discontinue olanzapine fluoxetine combination or adjunctive quetiapine extended release more often than we would want to because of an adverse event. So all in all, the other options seem to be better here. We can also take a look at the rates of akathisia, insomnolence, and weight gain of at least 7% from baseline. And overall, it turns out that the branded options seem to have a more favorable profile regarding akathisia in somnolence, as well as weight gain of at least 7% from baseline altogether. So this makes me gravitate towards those as my first choice. It seems to be better if I use adjunctive aripiprazole, adjunctive brexpiprazole, or adjunctive cariprazine, the ABCs as I call them, in that they have a relatively more benign profile, with the exception of adjunctive aripiprazole when it comes to akathisia. So this helps me practice evidence-based medicine, and it allows me to practice patient-centered care or therapy. By taking into account the patient's past history of, let's say, akathisia, sedation, or weight gain, I can select amongst the available choices, use my clinical judgment based on the relevant scientific evidence, and make a reasonable choice. So the patient profiles actually play a great deal in terms of my decision making, and this means asking the right questions. Thank you so much for your attention, and I hope this has been helpful to you. Please continue on the next segment, where I will discuss emerging adjunctive treatment options. Hello, I'm Dr. Leslie Citron, clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York, and adjunct professor of psychiatry and behavioral sciences at Northwestern Feinberg School of Medicine in Chicago, Illinois. There are several agents under investigation as adjunctive treatment for MDD, and this is for patients who have not adequately responded to monotherapy. Many are still in their early stages. However, there is one that has recently completed phase 3 of clinical development, and we expect it to be approved by the FDA in the not-too-distant future. Lumateperone is currently approved for the treatment of schizophrenia, as well as bipolar type 1 and type 2 depression in adults. And we anticipate it'll be approved as adjunctive use in major depressive disorder. Let's first review what our options are in terms of adjunctive treatments that have been approved by the FDA. There are only 5. They're aripiprazole, quetiapine extended release, olanzapine fluoxetine combination for treatment-resistant depression in particular, brexpiprazole, and cariprazine. They all bind to dopamine D2 receptors, either as antagonists or partial agonists, and they all have effective blockade of the serotonin 5-HT2A receptor. They differ in terms of affinity to the serotonin 5-HT1A receptor. One of the treatments we commonly use off-label is bupropion, which is not approved for the use adjunctively to treat MDD, commonly employed though, because it's easy to get, generic, and so on, but the evidence stacks up much better for the atypical antipsychotics. I wanted to make that clear here, because there were studies comparing aripiprazole with bupropion, and aripiprazole not only was more efficacious when added to the antidepressant, it also was better tolerated. Now, some of the common side effects we see are weight gain, increased appetite, akathisia, restlessness, somnolence or sedation, dry mouth, blurred vision. And common warnings and precautions include tardive dyskinesia, metabolic changes, neuroleptic malignant syndrome, leukopenia, orthostasis, serotonin syndrome, and seizures. For the most part, we're not going to eliminate the common warnings and precautions, but we could address the common side effects. Maybe not all of them, but maybe some of them. And that may be helpful for our patients who are reluctant to take what is currently offered. So let me talk about lumateperone. Its mechanism of action is different. It's a potent 5-HT2A antagonist with actually a 60-fold higher affinity to serotonin 5-HT2A receptors compared to postsynaptic dopamine D2 receptors. It is also a presynaptic dopamine D2 partial agonist. It is also a D1-dependent indirect AMPA and NMDA modulator. It is also a serotonin reuptake inhibitor, so that's different. We think reuptake inhibition may play a role in antidepressant effect. And certainly the difference in terms of affinity to serotonin 5-HT2A compared to dopamine D2 may make a difference here. Let's take a look at 2 phase 3 clinical trials. They have not been published yet. The only data that I had access to were posters of top-line data. As such, it's limited in the amount of data that was provided, and I could not do all the calculations I wanted to in terms of making indirect comparisons, but I'll do my best, as I will show you in a few moments. Let's talk about Study 501, a phase 3 study that was presented at a meeting in Europe, ECNP 2024. This study included almost 500 patients with major depressive disorder and inadequate response to antidepressant therapy, and patients were randomized to adjunctive lumateperone 42 milligrams or placebo for 6 weeks. Now, the dose of 42 milligrams was the starting dose and the ending dose. It is a single dose strength. The clinician-rated scales that I'm going to talk about is the Montgomery-Åsberg Depression Rating Scale and the Clinical Global Impression Severity Scale. The effect sizes measured in standard deviation units were robust, with a 0.61 and a 0.67 standard deviation unit degree of improvement versus placebo. The improvement was noted as early as day 8 and continued throughout the study. There was a patient-rated scale called the QIDS-SR-16, similar in some respects to the PHQ-9 that we're familiar with, that patients fill out and report the severity of their depressive symptoms, and it improved significantly with adjunctive lumateperone compared to placebo. Treatment-emergent adverse events occurring in the lumateperone group that occurred in at least 5% of patients and at more than twice the rate of placebo were dry mouth, fatigue, and tremor. Weight and BMI remained stable in both groups, and there were no notable changes in motor movements and no prolactin elevations or increases in cardiometabolic measures with lumateperone. Now, in order for a medicine to be approved by the FDA, there needs to be 2 studies in general that shows evidence regarding efficacy as well as safety. Let's go over another study. Study 502, which was presented very recently at Psych Congress 2024. Again, patients were randomized to adjunctive lumateperone or placebo. And again, the dose of lumateperone was 42 milligrams, single dose, no titration. And again, the Montgomery-Åsberg Depression Rating Scale and the Clinical Global Impression Severity Score were used as clinician-rated scales. The effect size, a little lower than in Study 501, but still respectable at 0.56 and 0.51 standard deviation units, respectively, for the MADRS and CGI-S. So this is a good sign. Improvement was seen as early as day 15. So this is a bit different from the other study where it was demonstrated at day 8, but still respectable and continued throughout the study. And again, the QIDS-SR self-reported depression scale also improved significantly with adjunctive lumateperone compared with placebo. Similarly, with treatment-emergent adverse events, those that occurred in at least 5% of patients and at more than twice the rate of placebo were dizziness, somnolence, dry mouth, nausea, diarrhea, and fatigue. And again, weight and BMI remained stable in both groups. No notable changes were seen in motor scales, and no prolactin elevation or increases in cardiometabolic measures were seen with lumateperone. Where will lumateperone fit? Perhaps it'll be similar to bipolar depression, where I did have adequate data from all the options here to calculate number needed to harm compared to placebo. There is overlap with bipolar depression, that indication, with adjunctive use in MDD, and gives us a hint on what we can potentially see. Green means the number needed to harm is at least 20, which means I am less likely to encounter the adverse event of potential concern. And amongst the 3 newer options, cariprazine, lumateperone, and lurasidone, we have relatively good outcomes here with mostly green. However, there's an Achilles heel for each of the options, whether it be akathisia or somnolence, but not too bad here. The yellow means a number needed to harm of 10 to 19, which represents intermediate risk. So I can get away with using cariprazine 3 milligrams a day, lumateperone or lurasidone 20 to 60 milligrams a day, and generally be all right here with reasonably good tolerability for my patient with bipolar depression. So how acutely tolerable are the second-generation agents in major depressive disorder? Here's another heat map. And I have data for aripiprazole, brexpiprazole, all doses of chloriprazine at least 1 milligram a day, olanzapine fluoxetine combination, and quetiapine extended release. And each of these choices have a red in it. Red means a number needed to harm versus placebo less than 10. So, for example, for olanzapine fluoxetine combination versus placebo, the NNH for weight gain of at least 7% is 3. For every 3 patients randomized to olanzapine fluoxetine combination compared to placebo, you would expect 1 additional patient with weight gain of at least 7% in the short-term clinical trials. This is a potential obstacle to use. For quetiapine extended release, the red is for somnolence or sedation, where the number needed to harm value versus placebo was 5. That's pretty frequent if you use it a lot. And then for aripiprazole, at the doses used in the clinical trials, which were on the high side, the number needed to harm for akathisia as an adverse event was 5. So what's my prediction for lumateperone? I say here my best guess because I don't have the actual percentages for calculating NNH, but based on the data that I've seen so far with bipolar depression and the top-line results for MDD, I will predict that the number needed to harm for weight gain of at least 7% exceeds the threshold of 20. So I'm not going to be worried about that. And the number needed to harm for akathisia, I'm pretty sure will exceed that threshold of 20, so I'm not going to worry about that. What I'm going to be on the lookout for is the number needed to harm for somnolence and/or sedation. I think it'll be intermediate risk between 10 to 19, but I don't know yet. So this is where lumateperone will fit in. When you're concerned about weight gain, when you're concerned about akathisia, and you want an intermediate risk for sedation. So in someone who complains bitterly about sedation, probably not your first choice, but otherwise it may very well be. So let's use evidence-based medicine as our guide here to practice evidence-based care, patient-centered care. We'll use our clinical judgment and our patients' values and preferences, and as the relevant scientific evidence rolls in, we can make our decisions. Thank you very much for your attention, and please continue on to the next segment, where Dr. Mattingly will discuss key considerations in selecting adjunctive therapies.
Hello, I'm Greg Mattingly, an associate clinical professor at the Washington University School of Medicine in St. Louis, Missouri. I am also the president of the Midwest Research Group and president of APSARD, the American Professional Society for ADHD and Related Disorders. In this segment, I will discuss key clinical considerations for selecting adjunctive therapies for major depressive disorder, common pitfalls that all of us have made at one point or another, and strategies to individualize an adjunctive treatment plan. Let's talk about some of the potential benefits of adding adjunctive treatment options. The first treatment advantage, I would say, is retaining a partial benefit from that initial antidepressant. I don't want to give up the gains I've made. I know when I miss a dose of my medicine, I'm not as good as I am on the days I take it. So the first benefit of adding something on top is I can boost the response of the medicine I'm already taking without the risk of switching to something else where I may lose my response and the gains I've attained. Another benefit of adding an adjunctive treatment is we avoid the possibility of discontinuation symptoms that can happen when we try to stop an antidepressant. Probably all of us have seen that patient who isn't doing great, but they try to stop their medicine. Now they start having physical side effects, emotional side effects, anxiety, agitation, insomnia, irritability, stomach upset, migraine headaches. The list goes on and on. Another reason I have become a fan, and I think the field and all of medicine has become a fan, is we talk about multimodal treatments. We know many of our patients come in with a variety of symptoms. Some people come in with anxiety, some people come in with insomnia, some people come in with agitation, some people come in ruminating, some people come in with anhedonia. So we like broad spectrum treatments that tend to be multimodal in nature. So in depression, we now have a variety of baseline antidepressants. They work partially well for many of our patients, but quite often they fail to put them in remission. So we use an adjunctive treatment that has a different mechanism of action. I find this to be particularly beneficial when the initial medication is well tolerated. If I have a patient who said, I've had no benefit. I don't like this medicine. I hate the way I feel. It's terrible. that's a place where maybe an adjunctive treatment option is not your best benefit. So I listen to my patient. I let my patient guide me. If the initial treatment is partially better, but not all the way better, I look for a multimodal treatment with a different mechanism to boost their response. Let's think about some of the potential risks of adding adjunctive treatments. We've talked about some of the benefits, but the risk can be drug-drug interactions. Some of our antidepressants are strong inhibitors of 2D6. And if I use an adjunctive treatment that goes through 2D6, my blood levels will go up dramatically. Other antidepressants are strong inhibitors of 3A4, 1A2. So I have to think about the combinations that I'm taking. Have they been tested? Have they been shown to be safe? And am I going to have significant drug-drug interactions? Side effects. When we start stacking multiple medications, we always want to keep the possibility of side effect burden. So I like my first medicine to be as clean as possible for side effects. I like my second adjunctive treatment to be as clean as possible for things like weight gain, things like sedation, things like cognitive issues or emotional blunting. I want medicines that help to counteract each other's side effects whenever possible and try to always keep in mind the possibility of additive side effects. Increased cost. This is a place that we keep in mind. When we add 1 + 1, we often wind up with 2 copays. So it's important to think about what is the cost of our initial treatment. Hopefully that's a generic treatment option for most of our antidepressants these days. And then we keep in mind the adjunctive treatment. What's the cost for the copay? Do I have a copay card that can help to reduce those costs? Do I have samples that can get a patient started where they can try it for several weeks before they have to pay out of pocket for the adjunctive treatment option? Another question that you will get from patients is, I'm feeling better. I like what you've added. How long do I need it? We have several treatment options that do have relapse prevention data that the long-term treatment with this adjunctive option helps to prevent relapses. The question I get quite often is the flip side for my patient. I like the medicine, you're boosting my response. I like the adjunctive treatment. I'm better. My moods aren't as swingy. I'm not as agitated. I'm not as anxious. I feel better. Do I need my baseline antidepressant? And to date, very few, if any, studies have said when I boost with an adjunctive treatment option, what happens if I pull that baseline antidepressant away? So that's going to be a place with individualized treatment for your patient. We like to keep people in remission for a minimum of about 6 months, and then we'll think about what we do after that as far as maybe peeling back one of the treatment options that's had less benefit. Key clinical considerations in selecting an adjunctive treatment. So we always want to be evidence-based. Which adjunctive treatments have evidence? We want to stick with medicines that have consistent benefit, that have data about both benefits, side effects, and risks associated with using them in interactions. So potential drug-drug interactions, were these safe combinations? Side effect profiles, were there additive side effects or did they seem to help counteract each other's side effects? We're getting to a world of looking at specific individualized treatment. So were there specific residual symptoms? Did the patient not have enough energy? Did they have anhedonia? Did they have too much anxiety and irritability? Do they seem to be that patient that has mixed symptoms? And then finally, we always want to come back and look at our stack. What is our stack of medications? Can we help to minimize polypharmacy by moving one of the medicines out of that stack? Maybe I can get rid of 1 or 2 of those with long-term management and looking at which treatment options have the highest side effect profile with potential unclear benefits. Some of the other things we think about is this is always patient-centric medicine. What does the patient tell me is important? Maybe the importance is I can't sleep. Maybe the importance is I blew up with my family. Maybe the importance is I can't concentrate. Maybe the importance is I'm less depressed, but I feel flat and numb. So patient preference tends to guide our outcomes. We've already talked about it, but what is the cost of treatment? No medicine works if I can't afford it. No medicine works if it sits in the bottle. Pharmacogenetic testing. This is a place that I don't routinely dive in with all of my patients, but there are certain medications that have specific cautions and warnings for people that are known to be 2D6 slow metabolizers. We may have a patient who's had an unusual set of side effects, and that's a place where I may want to do pharmacogenomic testing to see if they are a slow metabolizer, a rapid metabolizer for various antidepressants. So I don't do it always, but I never say never. It's another place where I'll listen to my patient. They'd like to learn more about their genetic background to help predict which medicines might have side effects or be less effective for them. Common pitfalls. One of the common pitfalls is bupropion. We all like a little whiff of dopamine. Unfortunately, that strategy has not worked consistently for patients. It's something we all do, but it has very little evidence. I've been part of 3 different research trials. none of which did bupropion separate from placebo. Bupropion has failed most of the adjunctive treatment studies, never got an indication as an adjunctive treatment option. I was just at a lecture recently, a CME lecture. Eric Lenz, the chairman of the Department of Psychiatry from WashU, did an adjunctive treatment option where bupropion had a higher risk of fall rates in geriatric patients with depression. So we always want to go to where we have evidence on both safety and efficacy. Let knowledge guide our outcomes. Keep in mind, once again, drug-drug liver interactions. So effects would be aripiprazole with fluoxetine. Fluoxetine is a 2D6 potent inhibitor. Paroxetine, very strong 2D6 inhibitor. Duloxetine, very strong 2D6 inhibitor. We think about carbamazepine, which speeds up metabolism of other medicines, may drop their effects. Quetiapine and 3A4 inducers or inhibitors. Olanzapine and 1A2 inducers inhibitors. Brexpiprazole, which is metabolized through 2D6 or 3A4. When we use inhibitors with them, we'll boost their levels. So we always want to keep in mind drug-drug interactions with specific 2D6 liver enzymes and other liver enzymes. Serotonin syndrome. I've only seen it twice in my practice. But when you stack medicines with multiple serotonin properties, you do stick it in the back of your mind. If somebody becomes tremulous, if somebody becomes anxious, if somebody becomes confused, you think about in the back of your mind, could this be serotonin syndrome? Let's talk about individualizing our treatment options. So we want to work together with this. My wording for the last 30 years with patients is, I'm going to listen to you, but you're going to guide me. And we're going to stick together till we get you better. We want to talk about establishing that therapeutic relationship. And why do we care about a therapeutic relationship? It's not just for better outcomes. It promotes adherence. It helps to create hope for your patients. So we want to work together to decrease stigma. We want to work together to create hope. A hopeful patient has a much better chance of having a good response versus someone who comes in scared, worried, concerned, feeling like treatments just don't work for them. Clinicians' treatment goals versus patients' treatment goals. Sometimes we have misaligned thoughts. Doctors and clinicians and nurses, we tend to think about symptom improvement. Patients tend to think about side effects and quality of life improvement. So I want to get your symptoms down to the PHQ-9. The patient says, Dr. Mattingly, I'm so tired I can't get out of bed. I haven't been able to be intimate with my loved one in a month. I'm stuck in a fog. So we always want to think about our treatment goals versus our patient's treatment goals. Measurement-based care. This is an important topic. We had a landmark meta-analysis come out of all of the studies that looked at measuring outcomes in depression versus not measuring outcomes in depression. Let me walk you through the data. When I measure your symptoms with the PHQ-9 or a similar rating scale, I was 65% more likely to get your symptoms to respond to your treatment. So 65% improvement on a response, which is a 50% reduction. If we move beyond that, if we looked at patient adherence, patients sticking with and taking their treatment options, we increased adherence to treatment by 70% when we measured patient symptoms. They knew we were adjusting things. They knew we were spending time. They knew we were looking for residual symptoms. Patients stayed on the bandwagon and gave things a chance. So a 70% improvement in adherence with measurement-based care. And finally, getting people in remission. Measurement-based care had an 85% increased likelihood of getting the patient's symptoms in remission. We didn't leave residual symptoms hanging out there. Maybe I'm less depressed, but I have anhedonia. Maybe I'm less depressed, but my energy isn't back. Maybe I'm less depressed, but my concentration isn't back. And the PHQ-9 tracks all of those, and it has a safeguard by also measuring suicidal symptoms. So measurement-based care, it had a 65% increase in response, a 70% increase in adherence, and 85% increase in remission. So we help to get better outcomes, we get people better quicker, and we help to prevent relapses with measurement-based care because we catch those early in the treatment course. So some of the outcomes that I would think about in measurement-based care, we call them our vital statistics. Our mental health vital statistics include the PHQ-9, the MDQ, the ADHD-RS, the GAD to measure anxiety and also just levels of distress, and a 9-item trauma screener, a PTSD trauma screener. We call them our mental health vital statistics because we want to get them with each and every patient. And our patients have learned that this is an important part of their care, measuring outcomes to get better outcomes for our patient. Another rating scale that's become very popular, we don't call it a vital statistic, but it starts the conversation with our patients, is the Q less Q. It's the quality of life and enjoyment scale. It has 16 items. It's filled out by your patient. It's free. And it talks about things like, do you look forward to the weekend? Do you feel intimate with your loved ones? Do you feel hopeful about the future? And it has a specific question on medication satisfaction. Do you like the medicines you're currently taking? It's a great way to practice holistic care, and it's where the field is moving. So life engagement, reward, satisfaction, patient-rated outcomes tend to improve functional outcomes for our patient. With every new depression trial, the FDA is now mandating that we have patient-rated scales that measure function, quality of life, and engagement. So I always say one of the biggest unmet domains in mental health treatment is reward, motivation, and drive, quality of life, and engagement. Those are key areas that we're learning to measure. They predict functional outcomes. They predict wellness for our patients. Let me thank you for joining me in this activity about the importance of adjunctive treatments, boosting response. How do you pick and choose to have individualized treatment for your patients? And finally, a discussion of the importance of measurement-based care. Thank you for joining me.